Professor Wang, and thank you for the very good presentation for William. And I have one. Oh, okay. 这样能听到吗？可以啊。Okay, I have one question for William, Dr. William, and for the case, this patient has HER2-low expression and potential PIK3CA YES1 mutation. For second-line treatment, should we primarily consider ADCs or combination regimen of endocrine target agent? Please explain your rationale. Thank you.
Yeah, so I think, because a drug like Trastuzumab Deruxtecan is so active, everyone is very tempted to use it immediately. And, the data that we have, in the earlier trials is, although we now have first-line data showing it's active, you still get a survival benefit in the second line. So I think usually when patients change from endocrine therapy to chemotherapy, they don't always come back to endocrine therapy at a later time point. So one thing I would think about is whether or not the patient has any immediately threatening disease. If they had a liver full of disease and they were rapidly progressing, I would certainly consider TDXD in that setting. If you feel like you have some time, and I was describing this patient as having some progression, but a good functional performance status, liver function normal. If she had a PI3 kinase mutation, or if she had an ESR1 mutation, I would still consider endocrine therapy. But if you were worried, or the patient was rapidly progressing, or had bulky liver disease, then yes, I would think about using TDXD preferably.
Yeah, Dr. William, for this patient, if the patient had a ESR1 mutation, and you still consider to use oral SERD, you use a single agent oral SERD, or the combination oral SERD we combine with other targeted therapies such as CDK4 and 6 inhibitors or other targeted therapies.
Yeah, so, that's an interesting question, because even though all the SERD shows some activity, no one wants to give a SERD as monotherapy in all the trials. They're all being combined with something. And obviously in the EMBER-3 trial, you saw that imlunestrant as a monotherapy works, but if you combine it with abemaciclib, you get even more benefit. So I think that could be considered. And then even drugs like elacestrant, they're being evaluated, as you know, with PI3 kinase targeting agents. They're being combined with everolimus. They've been combined with everything. So they seem to have more activity when you combine them with something. You could certainly consider elacestrant as a monotherapy or imlunestrant as monotherapy. But if they had, again, more threatening disease, the debate would be, do you give them a doublet of a SERD in something, or do you just pivot to TDXD? So the thing that's happening in ER-positive breast cancer is we have many more options than we did a year ago. And now the challenge is figuring out the right way of using them.